All right, let's get right into it. We're talking about a condition that's way more common than you'd think, and it's often completely silent until it's a huge problem, a blockage in the main artery going to your brain. Today, we're going to unpack a massive shift in how doctors are handling this risk, and trust me, this new playbook is a total game changer.
So just imagine this for a second. You go in for a scan, and your doctor comes back with the news, we found a significant plaque buildup in your carotid artery. You know, the main pipeline for blood to your brain. What's your first gut reaction? For pretty much anyone, it would be, okay, we got to get that out of there, right? Let's talk about surgery.
But what if I told you that for the vast majority of people in that exact situation, rushing to surgery is actually the old way of thinking? The best approach today, the one that's now the standard first-line treatment, looks completely different.
To really get why this all changed, we need to understand the condition itself. We're dealing with a silent but incredibly serious risk.
The official name is Asymptomatic Carotid Artery Stenosis, or ACAS. Let's just break that down real quick. Asymptomatic means you feel totally fine, no symptoms, no warning signs at all. And carotid artery stenosis is just a fancy way of saying there's a narrowing in those critical arteries in your neck, all because of plaque buildup. And this scan right here gives you a perfect visual of what we're talking about. This is an MRA. See those two big vessels heading up the neck? Those are your carotids. Now look really close where that arrow is pointing. See how the artery just pinches inward? That's the stenosis. It's literally a bottleneck restricting that vital blood flow on its way to the brain.
And make no mistake, this is a big deal. Even though it's silent, this exact condition is the root cause of about 1 out of every 10 strokes. So yeah, figuring out how to manage it is absolutely critical.
So, for decades, how did we do that? Well, the approach was very mechanical. It basically treated the problem like a clogged pipe in your house. And if there's a clog, what do? You call a plumber to clear it out. That was the old surgical playbook. The thinking was really straightforward. If a scan showed that the artery was more than 60% blocked, it was seen as a ticking time bomb. It just made sense to go in there and physically clean out the plaque. It was an intuitive fix to a physical problem.
And this wasn't just a guess. It was backed by some pretty solid data for the era. Big studies showed that surgery could chop a person's annual stroke risk in half, from around 2% a year down to just 1%. Back then, that was a huge victory, and it pretty much cemented this plumbing approach as the gold standard for a very long time.
But then, everything started to change. Our whole understanding of the disease evolved, and the game was changed not by a better surgical tool, but by much, much better medicine. This is where we enter the era of the modern medical shield.
And wow, this slide right here tells the whole story. Just look at these numbers. Back when those classic surgery studies were being done, the best medicine they had still left patients with a stroke risk over 2% a year. But now, with this modern medical approach, that risk has been absolutely crushed, all the way down to a range of 0.35 to 0.5% a year. That's not just a little better, it's a revolutionary leap forward.
So what is this powerful new strategy? Well, it isn't one magic pill. It's a whole comprehensive approach called best medical treatment, and has proven to be so incredibly effective that it has forced us to rewrite the entire rulebook.
The shield really has 3 main layers. First up, powerful statin therapy. This does more than just lower your bad cholesterol. Its real superpower is that it stabilizes the plaque that's already there, making it less inflamed and way less likely to rupture and cause a stroke. The second layer is all about lifestyle. Things like a heart-healthy diet, quitting smoking for good, and getting blood pressure and blood sugar under tight control. And the third layer, sometimes, is antiplatelet therapy, like aspirin. This one's a bit more controversial, because doctors have to do this careful balancing act between preventing a stroke and causing a serious bleed.
So, if medicine has gotten this good, where does that leave surgery? Well, it means the role for surgery has shrunk a lot, and the rules for who should even consider an operation have gotten much, much tougher.
Just how much tougher are we talking? Well, current estimates suggest that only about 10% of all patients with this silent condition might actually need an invasive procedure. Think about that. That means for 90% of people, best medical treatment is the answer, full stop.
And this slide really gets to the heart of the new thinking. We've shifted from seeing this as just a plumbing problem to seeing it as a biological one. The old question was simple: how much blockage is there? But the new, and frankly more important question is that plaque biologically unstable? See, it's not just about the size of the clog, it's about how angry and volatile it is.
So, how can doctors tell if a plaque is angry?
Well, they look for specific red flags, things like tiny little clots called microemboli that are breaking off, or they can see bleeding inside the plaque itself on an MRI, or they might see signs of active inflammation. These are the markers that separate a stable, quiet blockage from a truly dangerous one.
And all of this leads to an incredibly high bar for surgery. To even be on the table today, an operation has to prove it can get a patient's annual stroke risk down to less than 0.5%. That's a target that modern medicine can often hit all by itself without any cutting.
Okay, let's pull all of this together. What does this new playbook actually mean for a patient? What does the modern journey look like for managing this condition? It's a really clear 4-step path. It all starts with step 1, getting diagnosed with imaging. But step 2, for almost everybody, is immediately starting on best medical treatment. That is now the foundation. Step 3 is keeping an eye on things, monitoring for any of those signs of plaque instability we just talked about. And only then, only in that small group of people where those high-risk markers pop up, do you move to step 4 and have a conversation about surgery. This all leaves us with a really fascinating question to think about for the future. The trend is crystal clear. Medicine is getting better and better at taming this disease. So as these treatments keep improving, you have to wonder, is it possible that the need for preventative surgery for this silent condition might just one day disappear completely? It's definitely something to think about.